Welcome back to the Neurology 101 series of the ProPA podcast. I'm Dr. G, and we're closing out our movement disorders sub-series, part of our broader movement disorders and cranial nerve syndrome series, with a condition that's incredibly common but often misunderstood: Restless Leg Syndrome, or RLS. Let's dive in. Did you know that restless leg syndrome affects about 10% of adults in the United States, but fewer than half of those affected ever get diagnosed? It's not just a nuisance, it's a neurological sensorimotor disorder that can seriously impair sleep and quality of life. Let's dive a little deeper into the kinder patho. What is restless leg syndrome? RLS is a neurologic disorder characterized by irresistible urge to move the legs, usually accompanied by unpleasant sensations like creeping, crawling, or tingling. The exact pathophysiology isn't fully understood, but it's thought to involve dopaminergic dysfunction and iron deficiency in the central nervous system, particularly in the substantia nigra. How do these patients typically present? Well, key diagnostic criteria, we can use the mnemonic URGE. U stands for the urge to move the legs. R stands for rest, which worsens the symptoms. G stands for getting up relieves the symptoms. And E, evening or nighttime, makes it worse. Symptoms most commonly occur at night and can severely disrupt sleep, leading to insomnia, fatigue, and daytime sleepiness. It can also involve the arms in more advanced cases. So, how do we make the diagnosis? Well, it's a clinical diagnosis. There are no specific labs or imaging required. We want to evaluate for secondary causes like iron deficiency anemia, we can check a ferritin level, pregnancy, especially in the third trimester, chronic kidney disease, neuropathy, and medication induced like antihistamines, SSRIs, and even antipsychotics. So, how do we treat RLS? Well, we have some non pharmacologic therapies that we want to try first. We need to encourage regular sleep hygiene, moderate exercise, and tell patients to avoid triggers like caffeine, nicotine, and alcohol. Next, we want to supplement iron. If the ferritin is less than 75, we want to consider oral iron. We also can consider pharmacologic therapy for moderate to severe cases. These medications include dopamine agonists like pramipexole or ropinirole, which are first line, alpha 2 delta ligands like gabapentin, incarbapil, or pregabalin, especially if pain or insomnia is present. Watch for augmentation, a worsening or earlier onset of symptoms with long term dopamine agonist use. All right, bookmed versus street med. So, bookmed, RLS is diagnosed clinically using the URGE criteria and treated with dopamine agonists or iron if deficient. Street med, your patient says, "My legs feel like they're dancing on their own every night." You ask about sleep, iron, and meds, and suddenly they feel heard for the first time in a long time. All right, some clinical pearls. Think dopamine and iron. Always check a ferritin level and replete if low. Nighttime plus rest equals RLS. Rule out medications or comorbid conditions and watch for augmentation with dopamine therapy. Okay, let's test our knowledge. A 45-year-old woman presents with the urge to move her legs at night, relieved by walking. She's been taking sertraline for depression. What's the most likely diagnosis? A. Periodic limb movement disorder. B. Restless leg syndrome. C. Diabetic neuropathy. Or D. Parkinson disease. The answer is B. Restless leg syndrome. These are classic symptoms: the urge to move, worse at rest, and relieve with movement. SSRIs can worsen or trigger symptoms. Which of the following is the most appropriate to check in a patient with newly diagnosed RLS? Is it A. Vitamin B12, B. Ferritin, C. TSH, or D. Folate? The answer is B. Ferritin. Remember, iron deficiency is strongly linked to RLS. Ferritin should be checked and repleted if low. Final thoughts. RLS is more than just a sleep disruption. It's a treatable neurologic disorder that can make a big difference when diagnosed early. Use the URGE criteria, dig into the underlying causes, and help your patients finally get some rest. Next, we'll shift into the second half of this umbrella series, cranial nerve syndromes, starting with cranial nerve 3, 4, and 6 palsies, aka ophthalmoplegia. If this episode helped bring clarity to a common but often overlooked complaint, share with a classmate or a night shift buddy. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you in the next one.